Macular Society London Conference, 2013. Bill Harvey, Clinical Editor of Optician. The Changing World of Low Vision Aids.
Good afternoon, ladies and gentlemen. Fantastic to see you here. And I've got that slot where I've been told keep them entertained because they're already thinking about the journey home. I'm going to begin by joining in the Macular Disease Society loving, because before I start launching into the changes I've seen over the last 20 years in my profession, I have to say the Macular Disease Society will be quite instrumental in changing some of the attitudes ingrained in some of the practitioners who, rightly or wrongly, have been taught over the years to think of sight loss and visual impairment in terms of ray diagrams and mathematical formulae, and sometimes forget that behind those ray diagrams and formulae is a human being sitting there wanting some help. So a very brief introduction to maybe illustrate that a little bit more clearly, and then I'm going to talk a little bit about some of the low vision aids that we still today are recommending, and perhaps some of the problems that commonly crop up, often because of misunderstandings from the person prescribing them, not necessarily the user. And I'm going to touch a little bit on about the future regarding electronic aids as well, and about the way systems hopefully are evolving such that it's not just one person in a white coat with you for 5 minutes dishing out something without any backup or explanation. So that's really what I'm going to talk about the last half hour of today. My first experience, way back when, was any brummies in the room? Any brummies? Anyone care to admit to being a brummie? No. Hey! So there's a place, there used to be a volunteer place in Harvey called Focus, and I did my training down there. And one of the things you had to do, first of all, was try and understand what it was like to have some degree of visual impairment. And I noticed one of the chaps just a moment ago said that there's often a little bit of misunderstanding here. If people are labelled as sight impaired, then the whole of the rest of the sighted world imagine you can't see anything. And then when you are able to use your peripheral vision or you still pick up things, there's a certain, should we say, somewhat lack of empathy from that side. So we were first of all asked to walk up and down Harvey High Street with a blindfold on. Mine was the pink lacy blindfold because, as always, I arrived late. So I think I learnt more about surviving street gang warfare than actually sight impairment. But the other thing, which has been a big bugbear of a few of us over the years, is we were given these sight loss simulation glasses. I'm sure some of you are familiar with these. And they still use these at some of the universities. And the one for macular degeneration has got a big black splodge in the middle. And so all the students put these on, and they immediately move their heads and look around the splodge so they can still see reasonably well using their maculae. And in no way at all does it emphasize the fact that not only is the central sight loss initially often a distortion or a corruption of the vision, it can look quite scary, but it sort of gets across this very dodgy view that your peripheral vision is quite sharp and clear. Your peripheral vision has long been known for centuries to be low acuity, poor, blurred, good for picking up movement, but there's no way you could read a number plate in the periphery. Put on a pair of these simulation glasses, a sighted person will look to the side and read the number plate. Terrible, terrible, terrible. So my first point is that 20 years ago, eye care practitioners, as we're now supposed to be called, were being taught how people with certain types of sight loss, such as macular disease, see the world wrongly. Forward a bit then to when I moved down to London, worked at Moorfields for a few years. Fantastic and wonderful, but there, the refraction stroke low vision clinic, and I hate to say this, possibly not massively changed today. Any Moorfields people will probably want to run up and punch me in the face a second time. I'm here to be punched today, by the way, you probably noticed this. End the day on some controversy. We had a morning clinic timetabled with a list of patients, as we were told to say, not users or clients, whatever. It was patients. and you had to get through them by lunchtime. And so typically an assessment would be 10, maybe 15 minutes, no recall, and it was primarily based on seeing how far down the chart somebody might be able to see, working out what size target they might want to see, quick bit of maths, giving the person the magnifier with the briefest of explanation, and away you go. And our boss at that time, an excellent, sadly no longer with us, an excellent and wonderful woman, who some people in the room may well know, Janet Silver, smart and excellent woman, and in many ways put the fear of God into people like me, which made us actually go away and do some study, which people like me often needed at the time. But there were always financial constraints. So somewhere at the back of your mind, there were things like, don't ever give out a telescope unless absolutely justifiable, because our budgets won't stretch to that. Now that's like 15, 20 years ago. And hate to say it, maybe things haven't changed necessarily. Now, I started teaching the visual impairment course at City a while back, and we started to introduce to the students, a few of us, some elements such as how people can, through various changes to their perception of the world, come to adapt to a new world. Things like that model of sight loss, how to begin with. You have to encourage people to adapt to their new environment, and only once somebody is motivated to see the new environment, maybe then might you step in. And lectures on how to give advice on things such as the latest research with nutrition, perhaps the latest research with things like steady eye strategy and so on. And it was considered a little bit controversial at the time because still people wanted ray diagrams, and ray diagrams. But our argument was always that there's a whole UK out there filled with chests of drawers, filled with hand magnifiers and stag magnifiers that may well be gathering dust as the days go on. Some of them appropriately given, but never in a way that went along the lines that somebody would then go on to use them. The other change, though, back to our wonderful Macular Disease Society, was some work that they sent our way quite some time ago now, where there was an assessment amongst Macular Society members of what they really wanted from low vision services. And it was a big shock to optometrists that top of the list wasn't a magnifier. Top of the list was an explanation of what macular disease actually is and how it affects your vision in future. The implication being that with good information and good support from others, people themselves are often the best to sort out what their specific requirements are. Now, I hope that's not a controversial point of view, but some of the people I've seen over the years who have had the best success with low vision aids are often the ones that have taken something that has been recommended by somebody like me, gone away, adapted it themselves or adapted the way they use it themselves to meet their own environment better, and hopefully then got better use out of it. Which brings me through to the present day now, which is really my starting point, where I think there's two changes to the way low vision services, certainly from an optometrist point of view, are being presented, which I think are to our benefit. Because now I do a clinic over at the Action for Blind Centre over at Judd Street. And one of the key things there is it's a multidisciplinary approach. So in other words, I could come up with an idea that this person could use some task lighting, perhaps some contrast enhancement, and a couple of low vision aids. But if the rehab worker or whoever's also available on the case is also able to identify where that person lives at the moment, might do with some tweaks or changes to encourage that use, then that two-pronged approach usually gives the best outcome. And I know we're in a time at the moment where finances are being taken away right, left, and centre, but I would argue that one area where optometrists' input in the low vision world has improved, not least of all through support and information from societies such as the Macular Society, has been to identify that it should never be one bloke in a room with a white coat and a calculator dishing out a magnifier and saying, see you in a couple of years. The other sea change has and will be the increasing use to, and hopefully the increasing access to, electronic aids. And I will go on to talk about that a little bit later on in my talk. But just before we start talking about the magnifiers themselves, just to make sure people are still vaguely awake here. I'm just about keeping awake here. Who here uses an electronic aid of any sort at all? Electronic magnifier. Right, so here we go. So about a third of the room, I'd say, something like that. Fantastic. And keep your hands up, those people, and drop your hands if you had to pay for those yourself. Okay, so there's, I think, 4 hands still left up. Okay. Who here uses a standard low vision aid, a magnifier, or a stand magnifier, or a hand magnifier? Okay. Now, hands down if you sorted that out for yourself. So if you weren't given them by a practitioner, somebody, if you just sort them out for yourself, hands down. So that's about half of them down again. So you can relax now. That's got the circulation going. No DVTs in the arms today. A significant proportion of the room, obviously, are self-helping with advice, is my point. And I think it's imperative that practitioners, such as myself, can provide a support service in a network of support where advice is being given appropriately. Still, the majority of low vision aids given out by people such as myself, either in hospital low vision clinics or community low vision clinics, and these are very variable. In Wales, for example, the Welsh Low Vision Service is excellent. Optometrists go along, they do a little course, they get examined by Egypts such as myself, and then they get accredited, and they have a bank of low vision aids and some basic skills to help them see people with sight loss and can issue those low vision aids appropriately. And some of the local PCTs, before the homeopathic Jeremy Hunt started questioning things, some PCTs started to introduce at local level low vision services, as I'm sure you know, and there are plans even for companies such as the big bad Mammon, Specsavers and Boots to be involved in these in future, such that there will be a better community provision of low vision service. But ultimately, these are primarily optical low vision aids given out. And by optical low vision aids, the standard categories of those, if you like, are strong glasses or spectacle magnifiers, which is give an optometrist an easy word and they'll come out with a more complicated description of it. So spectacle magnifiers, strong glasses to me mum, hand magnifiers, stand magnifiers, or telescopes. And those 4 variously have been the mainstay. And if we go back 10 years, something like 95% of low vision aids issued through eye care services were of the optical variety. About 5% were CCTVs and various other things. And that 5%, CCTV is a bit outdated now. If we look at electronic aids in general, that percentage is due to increase significantly over the next few years, and something that all of us should be aware of as potential future extra help. As far as the hand magnifiers are concerned, one of the issues that we have here is back to my Moorfields experience of these often being issued by practitioners with a number on the handle, 3 or 4 or 5, because they've done a little calculation and they've worked out that this person, in order to read magazine print of N8, these figures to some equivalent, N8, they've worked out that to get them from what they can see with their current glasses to N8 would require a 4 times hand mag, so they'll dish out a hand magnifier, and away we go. One of the benefits of working somewhere like Judd Street is you can do recall appointments, and one of the common, they're quite difficult to just about hospitals, very difficult to get a recall unless the ophthalmologist reckons that's needed, but somewhere like Judd Street, often at the recall, one of the commonest things we see is that hand mag you gave me just wasn't really strong enough, I'm afraid. Can I have a stronger one? And I think part of the problem is that a lot of my bunch are quite slow to work out the fact that the number written on the handle is actually quite irrelevant. You can have a 4 times hand mag, but the way you use it can massively vary the amount of magnification you've got. So everybody should be aware of this straightforward point, and something the students eventually get their heads around, and that is that if you use a hand magnifier with your reading specs, or with a bifocal, or with something for close work, you've actually got an inbuilt zoom. You've actually got an inbuilt telescope, if you like. So if you use them with your distance glasses when you're out at the shops, and you just take a hand mag out your pocket to see what the price is, if that's not strong enough, and you've got it as far from the box of Persil as you can before it goes blurry, if that's not strong enough, yeah, you need a stronger hand mag. If, however, you've got your hand mag in use with your bifocals or your varifocals, and you move it from your Persil till it goes blurry, if it's not strong enough, just reduce the distance from the magnifier to your glasses. And so what you've got in your hand, which might have a 4 on the handle, might be 4, 5, 6, 7, 8, 9 times. 9, 8, 7, 6, 5, 4 times. So by moving it closer to your glasses, you up the mag. Away from your glasses, you increase the mag. Which brings me back to my first point of there's a whole load of hand magnifiers out there in drawers getting dusty, partly because the student or recently qualified optom that recommended it, either because they didn't have time in the hospital or because they didn't know themselves because they just pushed and just blagged their way through their final exams, didn't explain appropriately. Similar thing we have with the stand mags. So many of you will use stand magnifiers, and now that the illumination source is now moved to LED, which gives a much more even illumination across the surface of what you're looking at. And also your batteries last 8 times longer, which can't be a bad thing, because for some reason low vision aid designers have decided to make the way you change batteries similar to trying to break into Fort Knox to try and... Have you noticed that? I mean, it's fantastic. I noticed a Rubik Cube on the table. A Rubik Cube is much easier to do than change the batteries in a stand mag. I bet you know. Anyway, a lot of people, obviously, as the stand magnifier goes up in power, notice immediately, because the stronger lenses are necessarily smaller, they'll see smaller and smaller amounts of words at any one time. Now, because macular disease obviously knocks out the central part of your vision, the ability to scan along a line, the ability to have a reasonable field of view is very, very important. But how can you compromise, how can you manage to get the same magnification but improve the field of view with a stand mag? Well, we can't give a bigger stand mag because obviously the power of the lens goes down. So one of the options is to just encourage people again to move their head closer to the stand mag, improve the field of view. But again, one of the student misunderstandings is that the majority of low-powered stand mags are designed so that the light coming from them is actually divergent. They're designed to be used with readers or in younger people with accommodation. So if you move your head closer to the stand magnifier, you'll see more words, bigger field of view, fantastic. But the print starts to go more and more blurry, okay? And the reason they design them that way is not so that stand magnifier manufacturers can also sell more reading glasses to people and boost their profits. It's that by having the lens set slightly closer to the page gives a crisper image. There's less aberrations that way. But the flip side, it means that for most of your standard range of lower, your 3 to 4 to 5 times stand mags, they need to be used on the page with the light on, usually with a reading spec or a bifocal. And if somebody wants more field of view, you can do that, but the bit that a lot of our friends in the clinics forget to say is, move your head a bit closer, and we need to make your readers a bit stronger in order for you to do that. So there are ways around this, but again, it's another area where hopefully the time spent in the clinic where people are having aids recommended to them also can be spent just making sure people are fully aware of how these things work, because in the past, I suspect this has been sadly lacking. Strong glasses, brilliant. If you can cope with the ridiculously close working distance, strong glasses give you the best field of view of all. You have a nice, wonderful, wide field of view. But there are issues there, and there's some exciting areas of research in this, which sort of touch a little bit in what our colleague a moment ago was saying about steady eye strategy. Because over the years, one of the things you do find is you might get 3 people come to you who have exactly the same level of vision, and you give them exactly the same strong pair of glasses or spectacle magnifier. 2 of them will go away and be able to cope with the close working distance and get their light sorted out so they can manage to read with practice reasonably comfortably. The 3rd person, same level of vision, can't do it. And you don't know why. You think maybe they're not motivated enough. You measure, and then you're giving them a much stronger pair than you would have predicted. And what actually is now becoming increasingly obvious is it's to do with where your macula becomes damaged. Because if your macula is damaged slightly on the nasal side, if you like, on the left-hand side at the back of your eye, and you read from left to right, you'll increasingly be looking into the blind spot. And if your blind spot is slightly shifted to the left, you'll have the same static acuity when you look down the chart, but you'll be looking into a more sighted field, if you're with me. And there are, as you know, everyone's familiar with the good old Amsler. Everyone knows, everyone's got their fridge magnet Amsler. But I think it's not outrageous to just suggest to you, you all know that the subjective nature of the Amsler makes it not the most accurate of assessments. But there are now, and we're just starting to play with some at City, there are now what are called microperimeters, which are special types of field machine, which can reasonably accurately map that area of scotoma. And that gives really good information, not least of all to help our colleagues who are discussing and doing some eccentric viewing training, where to put the box of tissues near the telly, so when you make the tissues disappear, the telly seems clearer. But also to explain those cases where the slightly dislodged central scotoma is bang in the middle of the reading scanning area, so you can perhaps adapt, and in some cases adapt quite dramatically, like getting people to read vertically, for example. All this, I think, has got some significant potential in the coming years. So keep your ears open to any news regarding microperimetry and steady eye strategy. As far as telescopes are concerned, if you ask any optometry student, if you go to City now and ask a student, when would you ever give a patient, or a user, they call them patients still, when would you ever give a patient a telescope, they'd always say, to read bus numbers. Now, as I'm sure you're aware, telescopes work quite different to the other types of magnifier. Fancy pants words warning coming up. There are ways you could achieve magnification. Relative size magnification literally just means making something bigger, like large print books or big buttons on your telephone. Relative distance magnification is allowing you to hold something closer, so it appears bigger. And that's, in effect, how specs and most of the optical magnifiers work. The image or the actual object itself are closer to you, so it appears bigger, and all the lenses do make it clear for you. There's no magic in the systems there. Telescopes use what's called angular magnification. By having 2 more lenses, they can actually bend the ray of light so it achieves a bigger angle at the back of your retina. But in order to do that, at least one of the lenses has to be quite a long way away from your eye. So by the time somebody's focused their telescope to see the moving target of the bus, they're looking up underneath the radiator with their leg under the wheel. That's probably a little bit coarse way to describe it. But for looking at moving targets, telescopes generally are not where it's at. The static spot tasks, aisles in supermarkets, train display timetables to say how late you're going to be for the Macular Disease Society conference like today. Perfect for that. And also, obviously, because these things are focusable, a lot of them have got a good near focus as well as distance. So with training, fantastic, but really for static. So often they have been overprescribed and inappropriately advised on. Bioptics are making still some inroads. A bioptic really just means a telescope that can be flicked down to give you a magnification and then flicked out of the way again when you just want to move around and rely on your still functioning peripheral vision. And I'm sure you know, some of you in the room are already well aware of this, there are areas in the world where driving with a bioptic system is legal. There tend to be some states in America where the population is sparse enough for perhaps nobody to be too worried. But there are pressure groups. The bioptic driving group in Europe is still quite an active pressure group wanting use of bioptics available. But if I'm serious now, a team up in Manchester has found that for walking around, a flip-down bioptic, especially if you've got money in your pocket and can get one that's got an automatic focus on it, actually are very useful in terms of allowing spot task assessment of whatever detail you want to look at, signs, so on, face across the road, what have you, and then flip out of the way so your peripheral vision still allows negotiation of the environment. Your peripheral vision is useful for that. So I think bioptics at the moment, because of the expense of them and because they're still viewed outside the standard NHS range of optical aids, aren't necessarily widely used, but I think there's some facility there. TV readers, the last of the optical one, is really just again a telescopic device, binocular pair of specs that some of you in the room. Has anyone got TV readers here with the wheels on the side? So hands in the air. Hands in the air. Keep your hands in the air if you find those really useful. Oh, not bad, not bad, not bad. Because, well done everybody, because again, in my humble experience, I've often seen these recommended in a way which is inappropriate. First of all, because they have enough field of view for the television to be appropriately positioned, but they're given often without any advice about moving closer to the screen, adjusting the screen to maximize the contrast as possible, possibly reducing the color to enhance the contrast, and also the fact that they do magnify very subtle images. I've had so many users come back to me that say that it's fine for watching for any length of time once I manage to put some rubber pads under the nose pads to stop them cutting half my head off. But even with your heart rate, the telly sometimes just moves with your pulse. Has anybody noticed that at all? And of course, if somebody who you're in love with walks in the room, the telly's all over the place then. Telly's all over the place. Which brings me to the electronic aids, and to final few minutes now, because I think this is where, to some extent, we have seen a sort of mini revolution going on, not only in terms of where the prices are and should be coming down, but also in terms of the actual usefulness of them. Now, about 10 years ago, we were given at City some portable video magnifiers to trial, and they had a zoom range of them about 5 times. You could do reverse contrast, you could do blue-yellow contrast, which, as you know, often with macular conditions can be quite useful. They had a freeze frame button, so if you're out in the shop, you could click the button. Then when you got home, you could bring up that image so you could remember what the all great and good. But one thing they forgot was these things needed to be treated with absolute kit gloves. So I got 5 of them, issued them to 4 people with macular disease and 1 youngster that we knew who'd got a type of cone dystrophy at the back of his eye. And I think within a day, all 5 of them phoned up saying, it's broken. They'd forgotten robustness. And as a man who's now well into reading glasses and got through about 6 pairs since Christmas, I fully appreciate the value of having robust things. So my point being that not only have prices come down, but over the last year, when we've done any trials on these things, they seem to be a lot more user-adapted and user-friendly. So to bring back to where I started, changes to low vision and low vision aids. 30 minutes, I've just had to do a bit of a potted version there, but to finish on time so you can all go clubbing in London. I'd suggest a number of things that we should take heart with. I think, first of all, not least due to pressures such as Macular Society type groups, the need for a multidisciplinary approach to eye care has finally been taken on board and addressed. And I can vouch for the fact that this is certainly the case in the optometry degree syllabus. No longer should you be seeing just one, used to be usually a bloke, in a room with a box of magnifiers and then sent away for a year with a get on with it now, love. Okay? I think certainly as we increasingly see local primary care schemes set up, they should have within them necessarily some multidisciplinary approach. And I think that is absolutely essential if somebody can take from those services what they need, whether it's a bit of hardware or just some advice, but also know that there's a point of contact, not just amongst fellow users, such as through groups like the Society, but other practitioners who might then be able to perhaps give them the follow-up advice. I'll give you two examples to illustrate that. I issued a magnifier quite some time ago to this absolutely wonderful elderly woman, and then I followed it up later on with a domiciliary. She had told me that the magnifier was absolutely wonderful, it was great, but from the layers of dust on the magnifier when I went round there, I could tell she was just being nice to the funny Mr. Harvey. But she tended to, or she wanted to read glossy magazines. She'd got one 100-watt bulb in the day before they started taking those out of action, without a shade, right in the middle. She'd got a standard lamp behind her chair, which she'd had for many years and never used. And the lighting was totally inappropriate. And because she, as well as macula, had some early cataract, in effect, as she'd got the room set up, she was making her vision worse, because it's the same as somebody shining a torch in your eye saying, now try and read, now try and read. So simply by telling her to get a lampshade and get a local task light shining away from her onto the wall, such that there was reflected light onto the glossy magazines, rather than a single reflection from part of the glossy magazine that again would have been a distracting source, the magnifier worked. But had she not had that backup, that would have been a problem. The other issue with the home visit, and I noticed your police do not cross murder committed here contrast strip all around the hotel today, fantastic. Without winning any interior design awards, our friend who was, should we say, circumferentially challenged, she was a big lass, was having difficulty negotiating around her house, and simply putting high contrast tape around some of the door frames made life a lot easier. Now, 20 years ago, I don't think that would have happened, certainly not in optometry world. My other story was to do with somebody who had themselves got hold of one of these mouse-powered electronic aids, and she also wanted some advice about the latest research on nutrition with macular disease. And first of all, we reassured her that the way she was using her mouse, which was not what the manufacturer had recommended, she got it rigged up so that she had the television displaying what she was reading on her lap several meters across the room, but she was comfortable with that because she'd watched telly at that distance for years. She didn't want to be doing a weird CCTV thing. She sat back in her favourite chair, telly was back where it always was, the wire was long enough, magazine on her lap, she could read the magazine across the room. She just needed somebody to say, yeah, that's fine. If that's what you're comfortable with, that's fine. Because she'd felt guilty doing something that was different to what the manufacturer had recommended. The other thing was she had been given inappropriate advice from somebody wanting to sell vitamin supplements. And one of the things that we're really keen on, and I know you've had the excellent, wonderful Hannah talking today, the evidence base is changing and getting better. All eye care practitioners, and can I just reassure you, my last point, can I just reassure you, there's a few of us, Hannah particularly so, that are really cracking the whip on this one, we should be telling people what the evidence says at the moment so you can make your own informed choice. If anyone foists some tablets on you with unrealistic expectation, ask them what the published evidence base is, and the dodgy ones will probably mumble, go red, and run out the door. So on that bombshell, it's been a pleasure being invited to come talk to you today. I hope some of that was useful, and any further advice, if that's of any use, I'm always happy to be nabbed on, okay? So thank you very much.